All right, we're going to start chapter 15.4. We're going to discuss mood disorders, schizophrenia, and autism. These are not all the mental health psychopathologies we can run into, but this is just kind of what the book shows as kind of a sampler platter of some of the ways that individuals can suffer. So the first one we're going to talk about is depression. We're going to talk about major depression. It's an extreme condition. It can go anywhere from mild to moderate, persists for months. In order to be truly considered depressed, we have to have these symptoms for over a longer period of time than maybe just a couple bad days. And it's a little bit different. We're not talking about the emotion of sadness. We're talking about a clinical, neurochemical, it's a bunch of behaviors. And basically what we know for depression is a person experiences really little interest in anything. Even the things that used to give them pleasure no longer do. And then they just lack the motivation to do anything. So we lose interest in food and sex, and biologically that's just not normal. We should be interested in eating and procreating. And then these kind of feelings of worthlessness, guilt, and powerlessness that don't fit the facts. So clients, if clients have depression, and they may just feel, oh, I just feel guilty, I feel worthless, even though when you look at the facts, they actually provide a lot of worth. There's very few things to be guilty about. Also, a lot of sleep or abnormalities. Individuals don't get, they go right into REM sleep and not as much of the deeper sleeps, the restorative sleeps. Individuals with depression are at high risk for suicide. We're going to talk a little bit about that as the slides go on. So here's a little picture here. Your average person on top goes through stage 1, 2, 3, 4 sleep, 3, 2, then REM sleep, and the cycle continues every 90 minutes. And then what we have is people with depression will have this. The first part will be kind of compressed, they'll have the same amount of REM sleep, and then they'll end up awake. So you can have a lot of broken sleep. Under the banner of depression and depressive disorders, we're going to have seasonal affective disorder, which is usually seen with winter, commonly seen in areas with little sunlight in that season. So we're looking at some of the northern latitudes where we have this kind of long periods of darkness, short periods of light. Light therapy, right? Exposure to UV lights is one of the most common treatments, along with some psychotherapy. Bipolar disorder, which is a mood disorder, used to be called manic depression. And what we have is this cycling of mood, right, between periods of deep depression and periods of mania, which is this kind of extreme exuberance, agitation, focus on goal-directed behavior. Individuals with bipolar, there's a huge genetic predisposition, right? You can tend to find it run in families. It increases your likelihood of having it. It's not a predictor, but it's one of those, just like everything else we've talked about, some epigenetic factors. If the genes turn on, you're likely to have depression. Also, but being in a family with depression also increases the probability, not as much, and we may think of that as some ineffective learning techniques, right? Some basic learning history of how do you deal with setbacks and problems, right? And depression would explain that. Okay. Basically, the younger the people have it clinically, people in your family with clinical depression below the age of 30, once again, is going to increase your risk, right? And no single gene causes depression. Prior to puberty, right, boys and girls have the same levels of depression, right? But as we move forward from adolescence on, women are twice as likely to experience it. Right? And there's a couple theories we got going on for that. Right? One is the hormones, right? We think there may be this piece of hormonal change that may create this problem. It's not a level of hormones, but epigenetically the frequent shift of hormonal changes may help or hinder depression. Right? Also, there's some ideas between coping. So they talk about men do some distraction. Women tend to dwell. Ruminating is not useful, so it leads to worse. Right? There's this difference in style. Probably one of the main factors also would be is who presents. So women are more likely to present from mental health. They do present as classical, depression, and men tend to show depression as irritability and also don't really go to mental health, so therefore they may be underrepresented. So one of the things that happens, and Kalat's a little bit off on this one, right? He's talking about depressed after negative life events, right? A death, a loss of a job, something really big. But also you can have depression can be triggered by any life event, serious life event. Sometimes we will see, the literature shows a lot of people, you get the job that you want, depression increases, the birth of a child, depression increases, moving to a new town, things like that. And so there's a little relationship between the scale of event and seriousness, right? So the death of a loved one doesn't mean you're going to be more depressed than losing a job. Both of them could be equal. And then what we know is a lot of severe life losses early in life create this kind of vulnerability for depression moving forward. Okay. Also, lack of social support. If you're not in a group, if you don't have a tight, it doesn't have to be huge, but if you don't have a tight network, that's going to increase your vulnerability. And then also kind of the way you interpret the life. Are you a glass half full or a glass half empty type person? Alongside the physiological and genetic components, right, there's certain things that are just neurotransmitters. Other part is just this kind of mental and cognitive style, right? And so how we account for successes and failures. So we have this internal locus of control, right, where individuals they feel they have some efficacy, they have some sort of, they feel even though something happens, they can modify their reaction to it, they can modify the way they look at it. And then external attributions feels like things just happen from outside. There's no real way to control yourself, right? And so these two techniques, explanatory styles, cognitive styles, can predispose you to depression, right? So consistent, right? People who blame themselves for failures regardless of circumstances, right? If you are always the problem, that's a pessimistic explanatory style, right? And a lot of these individuals with depression will view their failures as global, right? I can't do anything right, and stable, right? It's always been this way. It will always be this way. I never will get better. Whereas someone with a more internal locus of control will say, oh, something bad happened. I don't like it. I can move on. I can learn this lesson. Somebody with a more external focus of control is always like, this is always happening. There's nothing I can do about it. And so somewhere those can also be protective factors. It's not going to cure you. It's not going to be the thing that prevents you from having depression, but it will decrease the likelihood. Some of the ways that we can treat people with depression, right? We do cognitive behavioral therapy. A little talking about, building more of that internal locus of control. Medications, right? Depression can be pretty well treated by medications, including things now in the new world. We're doing things like ketamine, microdosing psychedelics, things like that, and then your standard antidepressants. And then there's some herbs. St. John's wort may be effective. You see a lot of trials for that in Europe, not as widespread here. Okay. It's a little thing of the selective serotonin reuptake inhibitors, right? We're looking at if serotonin in the serotonin hypothesis, we don't have enough serotonin in depression, right? The lack of serotonin creates depression. These serotonin reuptake inhibitors allow them to keep the serotonin neurotransmitters to float around in the synaptic cleft, and then it allows you to activate more serotonin and should decrease depression. And we have some pretty good results with this as a treatment. Another treatment is ECT, electroconvulsive shock treatment. This is an outpatient procedure. You can actually go to our hospital here in Wilmington. You get a dose of anywhere from 6 to 12 treatments. And basically, a brief electrical shock is administered to the brain. You get this convulsion, and then clients come out a little bit woozy, a little bit lack of memory, but it tends to decrease the depression pretty quickly. We're not quite sure how it works, but there is some efficacy to it for some really treatment-resistant depression. It wasn't so popular because of abuse, right? A lot of times we're talking about the 50s, 60s, 70s, given without consent, given too often, used as a threat, but really good for the treatment resistant or some of the strongly suicidal. All right, bipolar, right? As we discussed before, there's a depression, right, followed by a period of normalcy and then mania. When experiencing mania, there's this constant activity, inhibition, right? Extremely happy, highly irritable, really goal-directed, focusing on things like sex, getting jobs done, working hard, making money, pleasurable activities. Bipolar is wrapped into two different types of bipolar, right? We have bipolar 1 and bipolar 2. Bipolar 1, you need at least one full episode of mania, and there's some diagnostic criteria for that. Bipolar 2 is you have the depression, right? Both of them have this major depressive episode, and bipolar 2 has a hypomania, which is a milder form of mania. So you still have that pleasure-seeking behavior, that goal orientation, the flights of fancy, the expansive personality. It's just at a lesser degree. Right? Bipolar, you got about 1% of the population of the U.S. has been diagnosed with bipolar. Really difficult to distinguish, right? It can map onto attention deficit disorder. If the high manic stage, you can have that paranoia delusions, which would map onto a delusional disorder. Maps onto some of our personality disorders, borderline personality disorder, where you have this high emotional reaction, and people will describe it as mania when it might just be a high emotional reactivity. There's also some genetic influences. Bipolar 1, when you have these high levels of mania, lithium, it's a toxic chemical that's given. We're not quite sure how it works, but it works pretty well. There's a lot of side effects, and it really, really needs to be monitored. But that's kind of the coin of the realm, the standard treatment. And valproate and anticonvulsant drugs are also administered, and then we have some new generation mood stabilizers, which will at least, if not control it completely, but allow the mania and the depression to never sink too low or raise too high. Individuals suffering from mood disorders, depression, bipolar, also some personality disorders like borderline personality disorder, a lot of suicide. And so people suffering from depression and bipolar, borderline personality disorder, consider suicide as one of the ways to minimize their pain or maybe to get out of pain. A lot of data on suicide. We could spend a whole class on this, but basically what we're going to talk about is frequency of suicides is not super known. Some can look like accidents, overdoses, car accidents. Not everything is the standard Anthony Bourdain, very clear suicide. And then suicide rates change as a function of gender, culture, and age. More males complete suicides because of the means. They tend to likely use firearms. Women attempt more, but because they don't use as lethal methods, they tend to survive. So it's kind of a murky area as far as research goes. As I said before, women attempt more often but employ less lethal means than men. There's no dependable pattern, certain risk factors, right? So the number one factor for suicide attempts is, has someone made an attempt before? Substance use, right? A lot of individuals make these attempts while under the influence. History of losses, a recent loss, and a family history. If that's been modeled to you as a way to get out of a problem, right, that increases likelihood of suicide. Just a little FYI for you guys, what we're talking about. If someone's thinking about suicide, just treat them like anybody else who's distressed. You may want to offer support and friendship. Asking somebody if they're thinking about suicide won't put that idea in their head. There's a whole bunch of resources you can have. You look up on the counseling center. But this idea that we can't talk about it to somebody, you talk about them, right? You express their feelings of friendship, that you care about them, and then encourage them to seek professional help if they feel some sort of openness to it. Don't bite off more than you can chew, but also think about this idea as just talking about it, giving somebody an ear to listen to, not treating it like it's like you couldn't understand it, and just kind of letting them talk may be helpful. And then definitely get some professional help and help them get professional help. All right, so when we talk about mood disorders, right? Mood disorders are not emotions. Depression is not sadness, right? Depression is depression and sadness is sadness. Happiness is happiness and mania is mania, right? These mood disorders go beyond this typical spectrum, right? And they really interfere with your functioning. We are supposed to have a wide variety of pleasant and unpleasant feelings, right? We're supposed to have our emotions. And one of the things that's pretty interesting is the treatment over the last, 40 or 50 years has really improved, providing many people with relief. Whereas, maybe 30 years ago, depression would have been almost a life sentence. Now, depression is something that, with hard work, effort, and the right help, it can be lived with and overcome. All right, let's keep going. All right, Kalant puts this other piece. This is another interesting piece. So we talk about mood disorders. Now we're into this little thought disorder. All right, and so schizophrenia has been confused with dissociative identity disorder or multiple personality disorder. All right, this is something that we, sometimes in the terminology we say somebody's schizo because they act differently. They act one way in one situation, one way in another. It's not what we're talking about. The split in schizophrenia is this disconnect from emotion and intellect. All right, so our individuals with schizophrenia have some pretty distinct features, and you can see they kind of look at the world in a different way due to the disorder. All right, so schizophrenia, you're going to have this kind of, over time, a complete deterioration of daily activities. Right, individuals with severe schizophrenia are going to have a hard time taking care of themselves. They're going to need some sort of help for the rest of their life. You're going to see some common things like hallucinations, delusions, and thought disorders, incoherent speech. It'll be hard for them to communicate. Some really disorganized behaviors, and then a loss of normal emotional responses and social behaviors. So things that would make most people laugh, they're not laughing, they're not scared of things that other people are scared of, and then this kind of the glue that keeps us together, the polite responses, the not saying everything that's on your mind. Somebody with schizophrenia may have problems with that, right? And so those are things that becomes a very difficult way to live. Now, the challenge with schizophrenia is it's a very broad diagnostic criteria, and so two people could have schizophrenia but show completely different symptoms. And so what we can kind of break them down into positive and negative. And they're not because they're positive and negative because we like them or don't like them, right? This is very similar to when we talk about reinforcement, right? Positive means that the behaviors are there, right? So we got things like hallucinations, delusions. And then negative symptoms are this kind of lack of emotional expression, lack of communication, right? Lack of social response, appropriate social responses. Right? So the positive symptoms are going to have hallucinations, false sensory experiences, hearing voices is very common. Visual hallucinations are less common. And if you think about this, this is kind of, even those of us that are not suffering from a thought disorder, this is like walking down the street and thinking you heard somebody call your name. Right, or seeing something out of the corner of your eye. It happens to us on a regular basis. You're just going to see a higher base rate and a little more reality-like feeling for people with these positive symptoms. Like they're going to hear voices, command hallucinations, background sounds, or actually see things. Right. We also have these ideas of delusions, right? Delusions of persecution, right? Everybody's out to get me. Delusions of grandeur, like I am the greatest thing since sliced bread, I'm actually a king, I'm the leader of a country, or ideas of reference, right? So you're just kind of, you're referring to things in a different way. So this might be not the paranoia, but this idea that aliens are talking to me, and I'm the one who has a secret plan, and I'm trying to get away with it. Sometimes it's hard to tell unusual opinions and delusions apart, right? I mean, we all have some people that have some strange ideas. I'm thinking like the Flat Earth Society might be one right now that would be a hard one. And most psychotic disorders can't be diagnosed on this basis alone. Right? Disordered thinking's impaired utilization of executive functions, right? So deficits of attention, difficulty in switching rules and routines. right? So individuals will want to act the same way in different areas, right? Remember, we talk about all the time, right? The way you act in class is not the way you act at home or at church. Someone with schizophrenia would have a hard time switching those tasks. And then a difficulty with abstract thought, things that you can't concretely see. So as you can see, there's kind of an all-encompassing disorder that's really going to affect your ability to live. When we talk about schizophrenia, there's undifferentiated, catatonic, disorganized, and paranoid. Undifferentiated, you can see this kind of deterioration of daily functioning, some form of hallucinations, a lot of delusions, and inappropriate emotions. And they're not going to be super pronounced, right? This is going to be someone who's probably odd. It's definitely going to need help, but it's going to take a little bit of time before you're like, oh man, they got something wrong with them. Right? Catatonic schizophrenia, you're either going to see people that have this prominent movement disorder. They're either going to kind of freeze up, right, or have excessive activity. You're going to see a lot of psychomotor agitation, and they're aware of their surroundings, but their posture and movement has no relationship to it, right? So they're not going to change their movement style, walking through soft sand or walking, on grass, all of us, or walking on a sidewalk with people on it. Right, their movement style is going to be the same. So they might just kind of tentatively walk or walk like they're speed walking. And so they know that there's people there, but they're just not able to change their movement styles. Disorganized schizophrenia, this is, you have incoherent speech, extreme isolation, silly or odd behavior. This is kind of the things you see on probably what you see kind of more of those individuals suffering mental health disorders, on the street, mumbling to themselves, being alone, wearing the hoarding of things here in Wilmington as you drive around, and maybe in any kind of really urban areas, you see this kind of person, right, mumbling to themselves. Maybe they have a shopping cart filled with things, and so more often than not, they're suffering some form of schizophrenia. Paranoid schizophrenia is also another one, right? You can function in this, but you're going to have these elaborate hallucinations and delusions, themes of persecution and grandeur. Like, I've seen clients where they believed that they were being tracked down by drug dealers. I had another client that had some of this paranoid schizophrenia behaviors, where she thought, people were hiding snakes in her house, and she came into the office with a bag, supposedly with snakes in it. Yet she functioned relatively well out in the world. Like, it took a little bit of time to talk to her before you realized that something was slightly off. So that's kind of, you can see this, and somebody like this could probably function for a lot longer than maybe someone with disorganized schizophrenia or catatonic. The symptoms are not that obvious. So schizophrenia, about 1% of Americans have schizophrenia. The rates have declined, right? It seems to be there's a correlation with how developed the nation is. Not quite sure what that's about. Schizophrenia is one of the trickier disorders to really find a genesis for. Most frequently diagnosed in young adults, anywhere between the ages of 18 and 26 is when you're first starting to see it. Men tend to be diagnosed earlier than women, and then it seems to be an sudden onset. But what ends up doing with you doing a little timeline follow back and going through the client's past history or the individual's past history, you're going to see there's a period of time where you're going to see some markers during childhood. Then adolescence, you're going to see those symptoms go down, and then you're going to see this kind of increase in early adulthood if somebody's suffering from schizophrenia. Right, there's a genetic basis. If your identical twin has schizophrenia, you have a 50% chance that you'll have it. And so it's very difficult to control for prenatal effects. We don't know if it has something to do with some genetics turning on when kind of during post-conception and while being carried to term. Not sure. Quick little data, you can look at this yourself, right? But it's kind of showing the right relationship to persons with schizophrenia. Right, so if your identical twin has schizophrenia, you have a 48% chance. Right, if your parent has schizophrenia, you have a 6% chance. Right, schizophrenic mother adopted by non-schizophrenic mother, you're gonna have 17. if your parents, both your parents are schizophrenic, then you're going to have a challenge. Then it's going to be pretty high chance that you are going to have schizophrenia. But as you can see, as we get closer, farther and farther from the similarities of genes, the rates go down pretty quickly. It's not a single specific gene for schizophrenia. It's not a single gene disorder. There's also some evidence that it can develop when there's no genetic basis. And so there's probably some other pieces that we don't quite understand yet. We know there's some things like the hippocampus and the cortical regions are somewhat smaller than normal. And remember, hippocampus is learning, emotion. Some of those cortical regions will be smaller. Smaller than normal or larger than normal cerebral ventricles, which is the spaces between the lobes. So we're losing some brain mass. And then when we get to the prefrontal cortex, right, the last part to develop, the areas that we're going to, that control, allow us to regulate emotions, they're going to smaller neurons and fewer synapses, so there's less connectivity. A couple causes. Schizophrenia might result from neurological impairments developed before at birth, right? There may be some genetic parts. So poor prenatal care, difficult pregnancy and labor, mother's exposure to influenza. These are all factors that, while we can't put a finger at them, these are all factors that could lead us to having increased rate or increased risk of schizophrenia. How to treat schizophrenia? Schizophrenia is really something that's going to be their treatment is going to be very medically related. Not a lot of therapy can work for this. Therapy is going to be mostly working towards maintaining your med regimen and working around kind of your constraints to get you back into as close to a normal life as possible. So a lot of antipsychotic and neuroleptic drugs, they work slowly, so it takes some time, and they vary in effectiveness between patients. So one antipsychotic will work very well for one individual and not so well for another. There's a dopamine hypothesis of schizophrenia, right? This idea that if we have too much dopamine, you're going to have these positive symptoms. And there is some evidence towards it as some of the antipsychotics decrease the availability of dopamine. And then also a deficient stimulation of glutamate. It could also be not enough glutamate. So there's some evidence to this, but neither one of these is the number one cause. But we do know that these are factors in schizophrenia. Some of the problems with some of the antipsychotics is you get tardive dyskinesia, which is these involuntary movements. So you're going to have tics. And so what we've developed is atypical antipsychotic medications that were not first developed for antipsychosis, but now they do work. But then the flip side to that is you're going to have some problems with immune function. So you're going to have these kind of secondary infections, things like that. So it's a really difficult disorder to treat. And so here, antipsychotic drugs work better than placebo. Over time, it's just a fact, but they don't work. We're not getting these improvements. Over time, we're looking at about less than 50% are improved. This data is a little bit late, a little old. All right, the last one, this is kind of a serious mental illness. We're going to talk about this in kind of the idea of, this is what we've done in the DSM, the Diagnostic Statistic Manual. So we're going to talk about autism as a disorder. This is a little older, so we're going to talk about some things that aren't disorders anymore, right? It's autism spectrum disorder now. There's no Asperger's. But in this, for our purposes, because of the book, we're going to talk about it in the way of how the book breaks it down. And so autism is serious mental illness starting early childhood, right? So before age 2, so you can see this kind of early. We're going to have impaired social relationships, impaired communication, stereotype behaviors, any behavior that an individual engages in over and over and over again, repetitively. And then there's some other symptoms, right? All sorts of things. It's pretty varied. What we do know is if autism is not seen, diagnosed, and treated early, we're going to have some, depending on how severe it is, we can have some language and other cognitive delays. So they're delays. They don't mean they're always going to be there, but the earlier this is found, the better off the individual will be. Asperger's is no longer called Asperger's, and you're now just higher on the autism spectrum. And what we have is this kind of really high, not super high intelligence for someone for autism. We're going to be closer to regular intelligence, less cognitively limited, and they can function pretty effectively in situations once they learn the cues and learn the behaviors. And somebody with Asperger's could have a pretty decent life. I would imagine you probably know someone or grew up knowing somebody undiagnosed high, what we used to call Asperger's, and they're doing okay, if not pretty good. The other part for autism, right? There's some risk factors. So there's a genetic. So twin studies, if one twin has autism, has a high increase that the other one will have autism. There's also some evidence that as adults, males get older, right? This whatever gene is involved in autism gets imprinted in the sperm, and so your more older fathers are more likely to have children with autism. The idea that vaccines cause autism just doesn't pass the sniff test. What we realize is probably more likely is that as a child grows up, the first 2 years, there's a lot of vaccinations, and these are also when the symptoms pop up, and so we're going to have this kind of piece of this correlation of, child gets a whole bunch of vaccines, start noticing some different behaviors, right? Easy to put the cause on vaccines when children who aren't vaccinated still have the same rates of autism. So really that vaccine thing is not good science, and everything that the scientists who promoted this theory, everything he promoted was found to have been lies, and they were actually removed from the scientific literature, which is a pretty rare statement. All right. Schizophrenia and autism, and I'm not a huge fan of how Kalat puts them together, but this is what we got. They just show these kind of two issues, right? These two disorders that present in two completely different ways, right? So schizophrenia, people could present differently. The causes of their illnesses are different, and autism is the same way, right? Someone with autism, they present, depending on where they are on the spectrum, presents very differently. And so some of the questions are they actually single entities? Are there some sort of connection? We're still kind of, the data's out on that. Working real hard on it, but it's one of those things, it's a question, are we actually diagnosing something appropriately, and does our diagnosis have some sort of actual utility? All right, so that ends this chapter. Thanks very much, and I'll talk to you guys for the next chapter.